So, ladies and gents, a couple of bits of housekeeping before I introduce Dr. Goebel. You've probably had the recording and progress message come up on your screens. So please do be aware this is going to be recorded, and keep your screens off if you want to miss any chance of being caught on screen at all. If you can keep yourselves on mute for the course of the meeting, that would be great. And we're going to manage questions through the chat function. So use the chat function in Zoom. By all means, give thoughts when they come up, and we'll try and compile some of the questions at the end, and we can ask them directly to Dr. Goebel. So I think that's the housekeeping done. Perhaps it's good to go ahead and introduce our speaker. So it's a huge pleasure to welcome Dr. Andreas Goebel to do the Pain Forum, not for the first time. Last time I think you came to Bath, Andreas. And it would be nice just to say a couple of things about you. So Andreas is director of the Pain Research Institute at the University of Liverpool, and he's been a consultant and honorary consultant at the Specialist Walton Centre Pain Clinic at Liverpool for a very long time. His original training was in anesthesia, pain medicine, and post-trauma immunology in all sorts of places: Germany, USA, UK, and he's been at the Walton Centre and the University of Liverpool from 2007 to 2008. And in general, his research has looked at the role of the adaptive immune system in causing what we put in quotes unexplained chronic pain, and particularly looking at this in CRPS and fibromyalgia. So I think I'm saying things that are going to be absolutely part of the talk. So it's an absolute pleasure. And Andreas, if you're happy to get going, then please do.
Yeah, thanks very much, Jeremy, for introducing me and for inviting me. I'm going to see whether I can share this here. Let's see, is this correct? Is it okay? Yeah.
Yep.
Okay, let's see whether this works. So thank you again for inviting me. So I'm going to speak about symptom-based disorder. So I've widened this a little bit from pain, and you see here on the right upper side some of these symptoms that are reported in people who have post-COVID syndrome. And I think post-COVID has put this on the agenda more than it was before. We have, let's just see how this works now. Oh yeah, here now it works. So I've defined them as conditions characterized by symptoms more than objectively identifiable signs. And these conditions have received recognition more since the pandemic, I think. They include pain and fatigue disorders, POTS, functional GI and respiratory and sleep disorders, idiopathic tinnitus, and others. There's an overlap between these conditions and psychiatric conditions. Often people are anxious and depressed, or there may even be other psychiatric manifestations. They are very common, and they're of course, together far greater disability than diseases where signs are prominent. And we know that already from chronic pain, even chronic pain conditions by themselves, even just chronic back pain, but is sort of just on par with, in terms of disability, causing disability with the dementias. These disorders can be associated with subtle signs, and there's lots of research going on about these signs. But and this could be autonomic dysfunction, so that people have maybe dry eyes, or and then there's small fiber pathology, so people might not feel quite as much in their skin. And when one looks at the skin, then the small nerve fibers are slightly rarefied. But the importance of these objective subtle signs is dwarfed by the impact of the symptoms. So people have massive pain and just a little bit of small fiber pathology. And the underlying cause are typically not understood, and there are few effective treatments. Often they are reported post-infectious, such as now with post-COVID, or actually post-distress. So in fibromyalgia, that's well established, and also with meta-analysis underpinned that really people get this condition more if they had experienced toxic distress in the past. This is when I presented last year on non-inflammatory pain sensitizing autoantibodies, and I presented at that time our results in CRPS. In 2018, we had most of the results in CRPS that we've then published in 2019. We're already there, and I showed you that. And so over the last 4.5 years, I've been involved in the Royal College of Physicians Fibromyalgia Diagnostic Guidance, and I chaired that group. And I would show you a little bit of the pictograms that we've created, because fibromyalgia, in a way, is a mother of all pain conditions, and the somatic symptoms with fibromyalgia are often also found in other pain conditions and in other symptom-based disorders. We've demonstrated last year that there's very likely an autoantibody course for fibromyalgia, and I will say a little bit about a new class of drugs which has been developed by 3 companies in parallel, which I think maybe now for the first time giving us an opportunity to test what we found there in the laboratory, and a opportunity for patients to maybe have a drug that can really treat them. I will say a little bit about what we found in post-COVID syndrome patients. So the fibromyalgia guidance was launched this year in May, and we've developed that since 2019, and we had a lot of support from organizations, 15 Royal Colleges and other organizations. And there's a little picture from the launch meeting in Liverpool in the lovely Royal College of Physicians North building. It's really lovely. This has been hugely popular. So when I checked last 4 weeks ago, there were 15,000 downloads, which is a lot for a Royal College of Physicians paper of any kind. And this is one of the pictograms that the artists from the Royal College did for us. So we know that this is not just about pain, it's also poor concentration, ineffective treatments generally, including to normal physiotherapy, intrusive fatigue. And fatigue can be almost as bad as the pain for patients, and in some respects is maybe even worse in some respects in terms of their functionality, maybe not so much the quality of life, but their functionality. Widespread pain, hypersensitivities of all kinds, not just to pressure and scratching or so, but also often to visual stimuli, auditory stimuli. And this goes on, and people are overwhelmed often, and we have few treatments only. Poor refreshment from sleep. I think sleep is never refreshing, even if people don't get interrupted sleep. And as we know, and you've probably seen in the past few BAS fora, that there is now this new way of describing the type of pain that fibromyalgia is. And I think that a lot of symptom-based painful disorders have, which is these unexplained pains, and that's meant to be called now nociplastic pain. And thanks God we have that now, because before we had to try and fit this into these 2 categories of nociceptive pain, that is pain that is mediated properly through pain receptors in joints or in soft tissues, for example in rheumatoid arthritis, or we had to fit it into neuropathic pain, and people have really bent backwards to try and do this, but it's awkward, which in truth is really pain that is caused by a disease or lesion direct affecting the nervous system, the nociceptive system, and such as in carpal tunnel syndrome or in acute disc prolapse, causing radiculopathy, pressing mechanically on one nerve. So the nociplastic pain is different. It's meant to be caused by a disturbance of peripheral or central nervous system, and we don't understand the disturbance. Cannot be alleviated by surgery, we said, because our main point here in the guidance was to try, and I think it does work, to try and convince surgeons why it won't make sense to operate on these patients. And it's an abnormal augmentation process, either in the peripheral or in the central nervous system. And I encourage you to not ignore that it is meant to be either in the peripheral or in the central nervous system. In the UK, for some reason, this seems to be interpreted as a somatization, yeah, which is not really the idea behind nociplastic pain. It's not the idea that the brain does this all. The brain might be involved, so that is one way, or it's a peripheral nervous system. Often we don't know. So it just means simply there's an augmentation by the nervous system itself, the reason for which we generally don't understand. And this is another pictogram from the guidance, and I'm again showing this, although it was created for fibromyalgia. You can see that there is something that is common to chronic pains and maybe some other symptom-based disorders, and that is the ACR 2016 count, which tries to capture this kind of symptom complex of problems with concentrating, problems with sleep, hypersensitivities, and so on, that we've just seen, and we show it now in a moment again. And then in fibromyalgia, there is a kind of, it's not arbitrary, it's underpinned by a lot of research, but there is a threshold above which then people say, okay, if you have so many of these symptoms, widespread pain, if it's so widespread and other symptoms such as poor sleep and so on, then you fulfill these criteria. And in practice, and this is also done for GPs. GPs often see people that have less of these symptoms, and then they fluctuate, and they would at some stage fulfill these diagnostic criteria, and in other times not. And we've discussed that, and we've said if they, pragmatically, it might be still right to call it fibromyalgia in this case. But I'm showing this here as well because there is a fluctuation along this axis of symptoms. Some months people are better, some months people are not so good, and the symptoms are not just pain. And here are the symptoms in fibromyalgia. Troubles thinking or remembering gives you 3 points, maximally fatigue 3 points, and waking up unrefreshed. And then you can get 1 point for depression, pain or cramps in the lower abdomen, and headaches. And then you count this together with how widespread the pain is of a patient, and then you get a total score, and you can score then the fibromyalgia. So I'd like to challenge you now for a moment, and I wonder whether I can manage to actually see you, and I don't know how to do this. So let's just see where I have this. So do we believe that fibromyalgia type symptoms, so all these sleep issues and so on, do they always accompany chronic pain? So maybe I'm just stopping to share now for a moment. I see one sign up, and that's because no one else in the second one there. All the others can probably not show me a thumbs up or down because they're all behind a screen so that I can't see them. But think about, there's a thumb down, excellent. So you have the opportunity to put a thumb up or down. So the question is, do you think that chronic pain conditions are always accompanied, or your patients always have some of these symptoms that I've just described that accompany fibromyalgia? And if you have time or see technically how to do it, then please, under reactions, click on the reactions, and you can give a thumb up and down. And Jeremy gives an up or down. I don't know if that's possible. You can give me up or down or both. So that's good. Okay, so I don't see many. I see one smiley, which is also a good response to that. And let's just see now. Let me share this again now. So I go back to the and now I get a few more responses. Thank you. Excellent. Share. Here we are. So, so now coming next. Okay, so the hypothesis that I've had 20 years ago or so is that some of these unexplained chronic pains are caused by autoantibodies that are functional and not destructive and not inflammatory, and that they bind to pain nerves and change the way pain nerves work, or that they bind to cells just around pain nerves and then these nerves are changed, these cells are changed in their function, and they now produce mediators that excite the pain nerves, but in a small way, so just almost like over a synapse, not in a systemically inflammatory way. And even so, and then there's the additional complexity in complex regional pain syndrome, that these pain nerves are probably changed in the way they express their receptors by injury. Yeah, so that's the complexity in complex regional pain syndrome, and that complexity exists in some other disorders, but not, for example, in fibromyalgia. There's no physical injury necessary. And although I have shown this to you before, 4.5 years ago, I'm going to show this again, because I want to make clear that what this is, these antibodies. These antibodies are proteins that the body produces originally to fight infection. And if we don't have them, then we get more pulmonary infection and probably some other infections. But these antibodies work by binding to cells. So this is bacterium, yeah, and the bacterium has several different surface structures, and these antibodies are all different. They look the same here on a macroscopic level, but a molecular level, they look different from each other. And this antibody can only bind to this part of the bacterium, and this can only bind to this part. And once they're bound, we have one, as a body, we have one, because this here is a very potent stimulator of the immune system for other cells to recognize that something isn't right here, and to come and bind to it and then destroy this bound cell, the cell that has been bound here. Yeah, so that's where the antibodies do a good job. And the binding then causes inflammation locally and destruction of the target cell. Now, this system can go wrong, and goes quite frequently wrong to a degree, in that and that works like this. So we have cells that are constantly being rejuvenated, that die and rejuvenated all the time. This is a little kidney cell, and that little kidney cell will die a natural cell death. And these fragments of the kidney cell will be taken up by the antigen-presenting cell and will be presented to the adaptive immune system, which is responsible for the production of the autoantibodies. But because it's our own cell, and this little structure, this little tree is our own structure, even so that happens all the time, and the APC tries to entice our adapted immune system to now be active and do something, that won't happen, because the adaptive immune cell is rendered tolerant through a complicated process in the development of these cells. So they get it presented, but they won't do anything against our own structures, except if there's environmental damage, genetic predisposition, or also even stress. Severe stress can cause this, can disrupt this tolerance. And now, unfortunately, this B cell will now recognize this antigen, we call that, or this target, and will now be stimulated. And now, in response, as it would do with bacteria, it now produces many of these antibodies. And where do you think will they bind, these antibodies now? They bind to the live cell here, yeah, to the live kidney cells. And then, unfortunately, that causes inflammation and damage in immune cell infiltration. And so that's what happens when autoantibodies are present. Now, as a final step, to just remind ourselves that autoantibodies are normally working like I've just shown, but sometimes they have purely functional effects. They don't have this inflammatory effect. So, and here's an example of a condition called neomyotonia, where this is the two gray bars are the motor neuron cell membrane, and the motor neuron has channels here, many thousands of channels, called voltage-gated potassium channels, and these are important to regulate the membrane potential. After each time that the action potential, the red thing that you've just seen there, goes through, the potassium ions go out through the membrane, through these potassium channels. And if you have now antibodies binding just to these potassium channels and changing them or internalizing them so that you have less of those, then what happens here is that not so many potassium ions can go out, and you dysregulate the membrane potential. And in this instance, you dysregulate this without any inflammation. So there's no other effect happening. We don't fully understand why there's nothing else happening. It's got to do with this FC portion of the antibody, but nothing else happens. But now you got spontaneous discharge, and you got involuntary tremor or muscle fasciculations. Yeah, so that's the result of it. And so based on this was what we've done in fibromyalgia, and having shown this already, that a mechanism like that exists in complex regional pain syndrome, following a serendipitous observation, I contacted David Anderson and Stuart Bevan in King's College, and then consecutively, we also worked together with Camilla Svensson, a senior professor for pharmacology in Stockholm. And we tried whether this could work in fibromyalgia, whether functional autoantibodies may explain fibromyalgia. And the way we've done it in CRPS before, and I had spoken about this 4.5 years ago, CRPS being an uncommon condition, fibromyalgia being a common condition, we injected IgG, so this is the whole fraction of antibodies from patients, into mice. And if you do that, then if you're lucky, the mice get the same condition as the patient. So, and that is because the mouse is not so different from the human. And there's a lot of antibody, a lot of surface structures of the cells that are similar in the humans and in the mouse. So there were a lot of mice involved in this. And this study has had a major impact. So this is a huge attention score here. And we were voted top 10 science stories. Actually, it's the only paper about a year ago by the Guardian's scientists, so voted by scientists. And already there's been quite a lot of industry involvement because of this study and based on this study. And just to show again how we did this, so what you can do with the mouse, so we take the IgG, these antibodies that we hypothesized have amongst them pathogenic autoantibodies, functional autoantibodies. We take them from the normal blood from a patient, we purify just the Y-shaped structures, and so just the antibodies, and then put it into a saline, and then inject that to under the belly of a mouse, so it will be taken up by the mouse into the bloodstream. So the mouse now has human antibodies in it, and we check whether there's any pathogenic potential. And we check that first by checking hypersensitivities in the mouse. So most people with fibromyalgia are hypersensitive. So if you give them a hug, they will say that this is painful. And so that would include then the toes. And so you can test hypersensitivity in the paw by putting this little cone up to the mouse paw and electronically giving more and more pressure there. And the mouse will withdraw the paw the moment when it thinks this is too painful. And we all would withdraw our hand if someone who is very strong would press our hand. But if we have a fibromyalgia, we will withdraw the hand earlier. And so we're checking whether after having received these human antibodies, whether the mouse will withdraw their paw earlier because the mouse has become hypersensitive. And we found that we tested people with severe fibromyalgia from our pain management program, tested 8 patients and then later another 2 patients, and Swedish patients with moderate to severe fibromyalgia from outpatient rheumatology clinics in pools. Ours were tested individually, and we saw responses in the mice like that. So we had to just inject for 2 days, and then we already, or even 1 day, this is the first injection day, second injection day, and then we already saw that mice that have been injected with healthy control IgG were actually not affected at all, and mice that were injected with fibromyalgia IgG became very profoundly sensitive. So you can see here the threshold. So you needed much less of a pressure on their paws for the mouse to say this is enough and to withdraw their paw, which is a proof that there's something in the fibromyalgia IgG fraction that causes hypersensitivity, and here also cold sensitivity. So the mice wouldn't let their feet on a cold plate for as long. And this was all done in David Anderson and Stuart Bevan's lab. And here you can see that all these patients developed exactly the same, elicited exactly the same behavior, we call that, in the mouse for mechanical hypersensitivity, and most also elicited cold hypersensitivity. We then tested muscular strength, because a lot of people with fibromyalgia say that they've lost their strength. It's not just a pain effect, probably. There's some other effects there. And that could be reproduced. So you can test here, and that's presumably a rat. I'm not quite sure, but we tested mice, and you can see that the force that the mouse can elicit, and the mice like to hold on, so they try to hold on, but they couldn't hold on as much as you see here if they were injected with the fibromyalgia IgG. We tested also whether they develop small fiber pathology, and they did. So you can see here that even with the naked eye, this is how it should look like. This is the upper layer of the mouse skin after injection, for 10 days, or after 10 days of injection with fibromyalgia IgG. And you can see here, healthy control IgG, sorry, this looks normal. And here you can see there's slightly less of these green structures, which are the nerves. And this is better visible maybe here, where you can see the density of the innervation in the fibromyalgia injected mice is clearly reduced. And they also walk less over the night in their peak movement times, so they walk less. And our patients say, oh, that looks like fatigue, because they first walk okay, and then suddenly they stop walking. Good. So now I'd like to ask you that, can mice possibly develop fibromyalgia, given that fibromyalgia is a biopsychosocial condition? So what do you think? Have these mice developed fibromyalgia? Can I just show see a show of hands, please? Okay, so we've got a good no here from Jeremy. Okay, and a no from Ben. Is anyone else actually online, I wonder? And no other comments. Oh, there's some more comments. So that's good. So we get here so far a response that they haven't developed fibromyalgia, but they must have developed something. You will probably agree. But they've certainly developed some of the core symptoms. And then Ben says something here in that effect. So I'm just going to share. Thank you for that, everyone, and please continue to do that voting. I'm going to share again here. Okay, so we did a bit more, and that was done all in Camilla Svensson's lab in Karolinska Institute in Stockholm. And we looked whether why do the mice behave so clearly abnormally and so clearly like someone with fibromyalgia in some aspects. So they seem to display symptoms. So why is that? And that must be because these antibodies bind somewhere to change the function of some cells. And she checked, Camilla's team checked in the brain, and she couldn't find it in the brain. Any binding, there is no binding in the brain and spinal cord. We cannot exclude that there might be small parts of the brain where there is binding, but generally there weren't any antibodies in the brain. But she found antibodies here in the dorsal root ganglion, which is the structure where all the cell bodies live from the sensory nerves. Yeah, and so it would make sense to say, well, maybe something's going on here. Emerson Kroc managed to get human cadaveric dorsal root ganglia, having shown before, which I'm not showing, that the human antibodies bind in the mouse to the mouse dorsal root ganglia. He wanted to check whether there's actually truly autoreactivity to human dorsal root ganglia as well. So he got cadaveric dorsal root ganglion for people who've given their bodies to science after death. They did not have fibromyalgia. They died for other reasons. And he now used the fibromyalgia IgG from our patients and stained these human dorsal root ganglia. And you can see here in white the staining. So there's a lot more staining here than here, where he tried to stain with healthy control IgG. Yeah, and that's here you can see the difference. So they bind to dorsal root ganglia, and here you see several structures, and there's two types of cells here. There's actually a number of types, but two types of cells that we were interested in. One is called satellite glial cells, and one is called neurons. And it turned out that the binding is mostly to satellite glial cells, which surround the neurons. This is a culture where we did the culture then, and we are doing that now as well in our lab. And here's how that looks like in the dorsal ganglia. This big thing here is a nerve cell body of a sensory nociceptor, so a pain-sensing nerve. And that is surrounded by here this wall of satellite glial cells. So it looks like these antibodies bind to the satellite glial cells and change the way these cells function. And here the green means that they're activated, these satellite glial cells. And then that probably has an effect on the nerves. We don't know how that exactly works, but that so far we think that could be the reason. A serum from all severely affected patients were active. The mice invariably recovered, suggesting the promise of therapeutic strategies that can reduce serum antibody levels. And the mouse cytokine levels were not raised. So this was not an inflammatory condition, as expected. This is not the same as rheumatoid arthritis. This is not an inflammation response. This is unlikely, therefore, to respond to anti-inflammatory treatments. Yeah, this is a very special type of autoimmune activation. So how is this special? We showed something similar in CRPS before. What we can say is that this is, Camilla only found this in people with severe fibromyalgia. She hasn't tested the mild fibromyalgia properly with concentrating, so we don't know. But what we can say, there's definitely more of these IgGs in people with severe fibromyalgia, that's for sure. And no injury is required. In CRPS, we can do that as well, but we have to injure the animals. If you take even from a high intensity patient with high intensity CRPS, take the IgG and inject it into mice, nothing happens. Yeah, so it's not just the pain. In CRPS, you have to injure the mouse, and then the mouse will get exceptionally sore in the paw, like in the human being. So the injury itself is required in CRPS. In fibromyalgia, it's not. So I'd like to now say something before the next challenge question to everyone about how does distress relate to the onset of symptoms. And I'm quite keen on this because 4 out of our 8 fibromyalgia patients said that they think their fibromyalgia symptoms have started when they had experienced really horrible things. 4 didn't have that. And yeah, so far, I think our only way of conceptualizing this, or traditional way has been to say, well, if you get a lot of distress, something happens with your brain, and your brain develops symptoms. And this is either hysteria, in that the brain does something and changes, and instead of experiencing distress, the brain now experiences pain, yeah, as if, you know, the brain sort of makes something new. Or it's somatization, which is you might have a bit of pain, but because you're so distressed, your brain augments this so much that it's so much in the foreground, you think you're in a lot of pain. But here is an alternative, and that is, if you get an infection like after COVID, or you experience a lot of distress, you might activate the immune system in a special way if you have some genetic predisposition, and that causes then symptoms and causes functional autoimmune disorder. So then, do you think, can I just ask you, do you think that we can all develop fibromyalgia? Do you think you could develop fibromyalgia? Jeremy is unsure. There's some yeses. You might say this is a silly question, Andreas, but actually I've been asked this question now a number of times by people in my team. And I'd say, okay, I get a lot of thumbs this time up. This is nice to see some thumbs up. And I would like to point out, and we can discuss that later, I would think that we probably can, and indeed, I could tell you a few more stories about this, but that this could be even a question, I think, is part of the reason why we are so slow with developing, with understanding what's going on here. I think you're more likely to get this if you're poor and your poverty makes you feeling distressed all the time. You're more likely if you have other horrible things going on in your life. And if you succeed in studying medicine, you're less likely to be poor beforehand and less likely to have experienced a horrible thing. So there is a little bit of a disparity that you're coming likely from a background that is less at risk, at least, I would say. Yeah. So, and therefore we might have been slow. At least that's my hypothesis here for this. So, but thank you for your responses, everyone. I'm just going to continue now. And I think I have still a few minutes, I think. Just a few beyond fibromyalgia, because I called this this talk is about symptom-based disorder. So actually, my colleagues here, friends and colleagues, David and Wade in Stanford, have just published this in pain. So there may be things like that going on in other pain conditions. And if you think about what's happening in long COVID, maybe some of these symptoms, and also the overlap between pain and some of these other problems, maybe some of these other problems can also be caused by these antibodies. And we've done this here. We got from the Charité in Berlin. Richard Berwick has done that just now in my lab. Fibromyalgia, IgG, and this is how strong they bind to these satellite glial cells that we just discussed. And if you look at this here, painful long COVID, this is the yellow figure, binds almost as strong as fibromyalgia. So if you have a very painful, widespread long COVID, you have similar antibodies, it looks like. Whereas if you're recovered from your COVID, and they are all longer than 10, 12 months ago, COVID infection 12 months ago, recovered versus COVID infection 12 months ago, still having widespread pain, you get this a similar picture. So it could well be that that is caused by similar mechanisms. So coming finally to therapies, there's a few approaches that we could look at. Could reduce the antibody titer. Yeah, if we don't want them, we can just reduce them, and I'll talk about how to do it. And that's the only thing I'm going to talk about today. But there's other ways. So if there's little mediators involved, for example, between satellite glial cells and nerve cells, then maybe we can find a way to affect these mediators or the mediator production. Yeah. And finally, at some stage, if we can manage to find exactly what the antibodies bind on the target cell, then we might be able to modulate this binding. And there's some autoimmune conditions where people have managed to do that. But it looks like at this point, the most straightforward way would be reduction in antibody levels. And there are these new drugs out now, which are called FcRn receptor blockers, and 3 companies making them. And just so I think you'll hear more about those over the next few years. And they are clever because they, and I actually consult UCB, I should say that. So you might say he says they're clever because he gets consultancy fees, but I don't get them. The university gets the fees. So I just think they're really clever because what you have here is this little FcRn receptor, which normally in a normal functioning human will prevent the degradation of antibodies. So like with everything in our bodies, we constantly degrade and metabolize our own proteins. And that's happening all the time in our cells. And when they are degraded, then they're destroyed, nothing there anymore. But these little receptors can protect the antibodies. And what do you think? Do we want that protection in an autoimmune disorder that is antibody mediated? We don't want that protection. So we block this little receptor, and then suddenly all of the antibodies get degraded, and you get a reduction of the antibody level by 70 to 80%. And that has worked in myasthenia gravis. So that was published last year, large, and already the Argenx have got a license now for this drug. It works in myasthenia. And here you can see this is, they've actually now looking at Sjögren's syndrome, which often is associated with fatigue, and POTS. Yeah, another, you might say, symptom-based disorder, COVID-related POTS. So they're already looking at that. And I think they're going to start a trial quite soon. The alternative is that you could just mechanically take this out. And that is also very powerful with something called plasma exchange or immune absorption. So one thing I wanted to ask, last question, will a better diagnosis and pain treatment option for diagnosis, because we could develop diagnostic tests now using these antibodies, do you think that will improve the quality of life of all our patients with chronic pain? I'm going to be interested to see what you think. So now we suddenly can treat them better. We can reduce pain by 50, 60%, and we can also diagnose them earlier. What do you think? Will that improve the quality of life of all our patients? Some of them I get from Ben. I got a thumbs down here, 2 thumbs down. A few more thumbs down further here. Okay, thank you very much. So last little part, I think I'm coming to my summary now. Thank you. Okay. Not sure if this is true. Yeah, okay. I don't know. Yeah, I don't know why I'm off. Oh, I took myself off. Okay, good. So I won't go into this. I think based on these findings, there will be quite a lot of changes in the medical treatment of these patients with actually diagnostic tests and a number of biologics treatments. And companies have already started to develop this now, and there are trials about to start. So in summary, so symptom-based disorders are common, cause a lot of disability. And many people with chronic pain have more than one symptom-based disorder. They're often associated having other symptoms. And recent research has shown that some of them may be caused by these antibodies, non-destructive, non-inflammatory. And there are already some treatment options. And I would suggest there could be an amended biopsychosocial model which takes into account the distress trigger of the immune system. So people are, obviously, if they had such severe distress, often they are still exposed to the same factors. So this is another reason why people might be distressed when we see them in clinic. And we need more research to understand how infection and distress translate into immune activation, I think, and whether maybe this is even reversible with new types of treatments where that could be psychological. Thank you very much.
Thank you so much, Andreas. And it's always a shame about Zoom you don't get the rousing round of applause, which would be appropriate at this stage. So what I'm going to do is I'm going to ask everybody to sum up your thoughts, pitch some questions for Andreas in the chat. Because I'm the chair, I get to go first, and I'm interested. Andreas, well, maybe I won't get to go first because Ben's managed to pitch one for us. So, yes, can you read that one? Does IVIG, which may work via FcR blockade, alleviate fibromyalgia in patients with anti-glial autoantibodies?
Yeah, so IVIG is also a method to reduce these antibodies, high dose. So we tried low dose IVIG out of a different reason, because we thought we observed in clinical practice that it works. We didn't know about these antibodies by that time, and that did not work in CRPS. High dose is a 4 times higher dose. There's no published data on IVIG. Whether it's, even if it works, whether that's nowadays, IVIG is, if you like, an older drug, there may be more effective ways forward nowadays.
Okay, thank you. Can I ask a question about the transfer to mice model? Do we think it's pain condition specific? So, I mean, this may be a naive psychologist question, but if you took somebody else with another arduous, stressful condition, chronic asthma, chronic poorly controlled epilepsy, would we be confident that if we transferred the same autoantibodies, we would or wouldn't see mechanical sensitivity, thermal sensitivity? What's the guess?
Well, so we did this with CRPS, and they are all severe CRPS patients. So if you take the IgG from a patient with severe CRPS, and we've done it regularly, we've done this as much as with fibromyalgia before, and you inject it into mouse, nothing happens. Okay, so you need to injure the mouse.
Injure them as
so
well.
So that means it's quite unlikely that this is a stress issue, because these people with CRPS, unless we would postulate there's a special type of stress in fibromyalgia, I don't think that is the case. So it's not a stress response, and also not just a pain thing. It's something specific, biologic specific to fibromyalgia and CRPS.
Thank you. So should we go with Jess's question? Do you think there's a difference, i.e. in the FMS autoantibody titers or presence between patients where there's a clear trigger for their FMS versus the patients where there isn't a clear trigger? It's a little bit like the CRPS question.
No, that's a good question. So, and actually, I had the same idea as well initially. So I thought maybe let's just get people that have a clear trigger. So the first 2 patients or 3, we chose patients that, because I thought that's much more clinically intuitive that, because some people say really they develop from back pain to fibromyalgia within a few months or a year. So I thought, let's get those first. But then we became more brave, and we included everyone, including those that, they couldn't even say when they sort of gradually might have gotten more pain. And, so it looked, but it could still be that there's a difference. It's just that that they all have antibodies. It could be we don't know the molecular structure. It could be that there's something different about those that developed it quick versus the others. But certainly both groups have apparently these antibodies if the fibromyalgia is severe enough.
Thank you. So this question from Felicity, which is, for the layperson, how would you describe the mechanisms of fibromyalgia, which is quite a big one? And I would also like to just add to that, is there any relationship between your work and traditional concepts like central sensitization, or are these completely separate ideas?
Yeah, so that's interesting, isn't it? So you've got central sensitization in fibromyalgia, and these models so far we've only done for 14 days. Some of the measures I think that we've done would suggest, so there is actually, which I've not shown, there is actually a little bit of touch sensitivity as well, certainly in some of them, which would suggest that there's a degree of central sensitization evoked by these antibodies, and that must be secondary. So you stimulate constantly these peripheral nerves, and then after a while it looks like that you build up some what we call central sensitization, but that doesn't happen in everyone. And then the whole idea about fatigue and poor sleep and depression and anxiety, we haven't tested that enough, and we don't know whether it can be transferred in that way. You've seen the movement in the night, so the movement is reduced and only in the peak period, which could hint at fatigue, but we haven't done enough to really say something about this.
Thank you. And then the question from Sean is there any evidence or work done in children at all in this field? Pediatric chronic pain.
I mean, that's of course. So I mean, apparently, so I don't see children. So my friends that do see children say you can occasionally get that also in children. You can get fibromyalgia, and we can certainly not say, and we did for sure not start off with saying everyone with fibromyalgia in the adult world has these antibodies. That's absolutely not what we thought. So we would all have been delighted if we get 20%. So that we now see that in every patient is completely blown us away. And so I don't know whether, so in adults, we have yet to meet one preparation, if you like, where we don't get this, but we haven't tried it in children.
So this is from Becky. And yet any evidence that reducing psychological stress or distress has any impact on autoantibody levels?
Yeah, it's a good question. I think it's one of the crucial questions, really, in my opinion. And that's the companies have asked me things about what other ways might there be. And I think there's a lot of things that won't work, such as anti-inflammatory treatment. But if we can devise some sort of clever way of reducing, I'm not sure that actually reduction of distress just now is enough. So that, let's say you're in a high distress situation and you somehow manage to calm that down. We know from pain management programs that a lot of people manage their pain better. And I work at a large pain management program in Liverpool, and that can reduce certainly the flares actually. And that's in part because people deal with it better. And so there is a bit of a reduction, but it's generally that this disorder continues. And so, there's one thing is the social situation. So that was my question also before, because a lot of people will still be in distress, you can say, but nevertheless, my hunch is that you can't just by reducing now the present distress address that. So, but I wonder whether there's something like a kind of an engravement of what people have experienced somewhere in the body that is still active. I just wonder whether there's still some sort of a link to the horrible things that people had to experience, you know, whether we might not yet have the way to access this, and if we could, whether that could maybe then, you know, induce a downregulation again through mechanisms that we don't understand. But that's complete speculation, so I have no idea, you know.
I think it's plenty enough to keep us psychologists busy for a while, Andreas.
Yeah.
Okay, another one from Ben. So in rheumatology, we had reports of life-changing improvements in fibromyalgia, brain fog after a short course of oral steroids, which are prescribed from unconnected reasons. So if there's an immune component to these autoantibodies, do you think this could partly explain this steroid effect? Do you think there's a role for immunosuppression?
Yeah, that's an interesting question, and we always get that asked. So firstly, no one has, if that is really the experience, then no one has so far bothered to actually publish it properly, unfortunately. So we don't have good data. So a lot of people say that this is their experience, but then we also have other people that say, no, this, I've tried it 10 times and never worked for me. So it's interesting. And I don't want to deny that people have that experience if they treat them. But then the next question is also, how much steroids did you give? So conceptually, you would have to give a large amount, enough to suppress the whole immune system. In the doses that we normally give, which is medium or lower doses, you have the steroid effect on the mood and so on, which is sort of the steroid boost. So I can't tell you whether we would need a formal study to really find out about it. I would say that maybe a very high dose steroid treatment can temporarily calm this down. Yeah, but then why would it stay calmed down? I think you would come up again. But it's not the anti-inflammatory effect. It's the direct, you know, against the production of mediators, but it's a direct effect on the cells, probably, I'd say. So, but I, you know, so far it's all speculation, unfortunately.
Okay, thank you, Ben. Right, so probably got one or two left, and we've got a nice one from Jess here. When in the development of FMS as a clinical syndrome, do you think the autoantibodies develop? Could you screen serum of healthy patients and detect those with autoantibodies who would be at risk for FMS?
Yeah, that's another great question. So that's what we hope to do, to get a prospective study. Like you have pre-RA, you know, so rheumatoid arthritis actually has a prequel. So where people don't have the full-blown rheumatoid arthritis, but they have weird pains in joints. And you can already, and equally in diabetes, you can years before already detect that something is changing. And I bet you that something like that could happen here. In addition, we have here the complexity that a lot of people with fibromyalgia develop this out of a long-standing history of back pain. So God knows whether already in back pain you have some sort of abnormality, maybe, you know, that you can in the future actually detect. So yeah, that's exactly, I think that would be great. And I think people will look at that.
Lovely, thank you. Well, we're approaching the hour of 5, so I invite anybody to throw in a last question at this point if they would like to. I think that's actually been a really cracking set of questions in many ways.
Yes, great question. Thank you.
Last calls, going. Thank you, Becky. Okay, well, it remains, to thank Andreas very much, I think, for doing a great talk, and for also really doing terrific research, which has the possibility of making a true difference, both diagnostically and therapeutically. Lovely, really nice. So thank you. And for all of you who are going to sign off fairly soon, we will send around an after the event email. And just in case anybody came late or left early, we'll put a private link for a short amount of time to Andreas's talk video, so you can just catch up on anything you missed. And stay in touch with us, please. I know some of you guys follow us on Twitter and things like that for details of the next Pain Forum. For anybody who is interested in a more intensive psychological and behavioral training, not just for psychologists, but for the whole MDT, at the end of March, 30th, 31st, we are doing some intensive training here in Bath on acceptance and commitment therapy for chronic pain. So get in touch, and we'll put emails and things like that in the post-event email to you. So thank you all very much for coming. Very, very Merry Christmas to everybody. Thank you. Good night.
Bye.